Welcome to the deep dive. We are jumping right into a pretty wild paradox today
Yeah, we really are.
because, you see the marketing literally everywhere for this stuff, like fractional lasers promising vaginal rejuvenation and tissue tightening for women who are navigating menopause.
Right. It's plastered on every wellness clinic brochure.
Exactly. And it sounds like this high-tech, minimally invasive silver bullet,
It
right?
says it's great on paper, yeah.
But when we actually dig into the clinical guidelines, the FDA warnings, and the data from NICE, which is the National Institute for Health and Care Excellence, a very specific, highly critical question emerges from the sources.
It's a really vital question.
Right. And our mission today is to figure out, can these cosmetic tightening procedures actually make painful sex drastically worse if underlying vaginal dryness isn't treated first?
I mean, that is the core issue here.
Okay, let's unpack this because
Yeah.
the disparity between that glossy clinic brochure and the clinical reality is, it's honestly staggering.
It really is.
Yeah.
And to understand it, it requires us to, well, strip away all that aesthetic marketing terminology and look strictly at the biophysics.
Right, what's actually happening in the body.
Exactly. We are dealing with genitourinary syndrome menopause, or GSM.
TSM, right.
And we really need to look at what happens at a cellular level when thermal energy interacts with human tissue that is fundamentally compromised by estrogen deprivation.
Right, so to understand why a laser treatment might just completely backfire, we have to look at the environment it's actually entering, right?
Yes, the foundational environment.
Because with GSM, it's not just a localized issue of a patient feeling, dry. It's an entire pelvic ecosystem that's losing its primary metabolic driver.
What's fascinating here is the sheer scale of the biological cascade. Like, estrogen receptors aren't just in the vaginal mucosa.
Wait, really? Where else are they?
They are densely packed throughout the whole area. The urethra, the bladder trigone, and even the pelvic floor musculature.
Oh, wow. So it's systemic in that region.
Exactly. And in a well-estrogenized environment, the superficial mucosal cells turn over rapidly. They're constantly renewing.
Okay.
And as those mature cells slow off, they release glycogen. And that glycogen is the primary food source for the local lactobacilli.
Right, the lactobacilli, which are the bacteria keeping the environment acidic, right, keeping it hostile to pathogens.
Precisely. They're the ecosystem's main defense mechanism.
But then menopause happens.
Right. When systemic estrogen drops, that rapid cell turnover just halts. The epithelium physically thins out.
So the walls actually get thinner?
Yes. And without the constant sloughing of those mature cells, the glycogen supply dries up. The lactobacilli literally starve.
Oh, wow.
And subsequently, the tissue pH spikes from a healthy acidic 3.5 or 4.5 all the way up to 6.0 or higher.
So the whole chemistry of the area completely shifts.
Entirely. You lose the structural thickness, you lose the natural transudate, which is, the moisture that permeates through the vaginal walls, and you lose that antimicrobial defense.
And reading through the Cleveland Clinic data, this biological degradation translates into a very specific physical sensation for the patient, right?
It does.
Which is really where this clinical trap gets set, because women frequently report a feeling of looseness or laxity.
Right, they feel like something is stretched.
Exactly. They physically feel like the vaginal canal has stretched out, so naturally, they start looking into tightening procedures. But the anatomy tells a completely different story, doesn't it?
It's a profound misinterpretation of the symptoms. And frankly, a lot of aesthetic clinics capitalize on it.
How so?
Well, the vagina is an incredibly dynamic organ. It doesn't just permanently stretch out and stay loose like a worn-out sock simply due to age.
Right.
The sensation of laxity that these patients are experiencing is actually primarily driven by weak pelvic floor muscles and, crucially, a severe loss of tissue elasticity from estrogen-depleted collagen.
Reading the sources, I always picture it like an old rubber band you find forgotten in the back of a desk drawer.
That is a perfect way to look at it.
Right. Like, it hasn't necessarily been stretched by being wrapped around something massive. It is just completely desiccated over time.
Yes,
It lost all its moisture and its natural snap. So it feels loose, it lacks tension, but it's not because it was pulled. The material itself degraded on a structural level.
That analogy perfectly illustrates the diagnostic failure we see in these cases.
Yeah.
I mean, a patient feels that lack of snap, walks into a clinic asking for structural tightening, and the practitioner just complies.
Which is terrifying.
It is, because the underlying driver isn't mechanical looseness. It is profound cellular dehydration and hormonal starvation.
Right.
Treating that with a mechanical or thermal tightening device is basically treating a symptom by attacking an already compromised tissue.
Which brings us to the proposed solution that these clinics push, the laser, like the
Yeah.
fractional CO2 or ERYAG lasers.
Right, the rejuvenation machines?
Yeah, rejuvenation. The marketing implies they are somehow like shrinking the tissue back to a youthful state.
But they're not.
Right, so wait, we aren't actually pulling a drawstring here. What is the actual biophysics of these devices? Like, how are they interacting with the mucosal walls?
To understand the risk, you really have to look at the mechanism of fractional ablation.
Okay, let's get into it.
So these devices emit light energy that is highly absorbed by intracellular water.
Meaning the water inside the cells.
Exactly. When the laser hits the tissue, that energy converts to heat. It creates thousands of microscopic columns of thermal injury while intentionally leaving little bridges of healthy, undamaged tissue in between.
So wait, the goal is actually a controlled burn. You are deliberately injuring the tissue to provoke swelling and, like, a scar tissue-like response.
Okay, yes. You're relying entirely on the body's wound healing cascade.
Wow.
The thermal injury, which is ideally kept within a very precise window of 45 to 60 degrees Celsius, triggers the release of heat shock proteins and cytokines.
So it's sounding the alarm for the immune system.
Right. This recruits fibroblasts to the area to lay down new collagen and elastin fibers, which theoretically increases the epithelial thickness and restores vascularity.
Okay, here's where it gets really interesting, or I guess highly concerning.
Yeah, here's the catch.
Because I'm getting hung up on the physics of this. You just said the laser energy is specifically absorbed by intracellular water, right?
Yes, that's the primary target.
The water inside the cells is what converts the light to heat. So if the laser is designed to hit that very specific 45 to 60 degree temperature window by interacting with hydrated tissue,
Right.
what happens when the laser hits a vagina suffering from severe untreated GSM? Tissue that we just established is profoundly dehydrated, thin, and completely lacking in cellular water.
That is the exact point of catastrophic failure.
Like, what actually happens?
If we connect this to the bigger picture of thermodynamics,
Right.
the laser's safety profile relies on the water content of the mucosa to act as a buffer. In a healthy, hydrated environment, the water absorbs the energy, and it limits the depth of the thermal damage. The heat stays localized to the surface.
But if there's no water to absorb it, it just keeps going.
Exactly. The thermal energy isn't buffered at all. It penetrates far deeper and much more aggressively into the underlying stroma than intended.
Oh my God.
You are no longer creating a controlled microinjury. You are inflicting a severe thermal burn on pale, frail, inelastic tissue that has absolutely no metabolic reserves to heal itself.
And the tissue doesn't have the estrogen-driven blood flow to mount that healthy wound-healing cascade anyway.
Exactly.
It's like trying to grow crops in a desert by setting the sand on fire. You aren't going to stimulate a lush garden, you're just scorching the earth.
The scorched earth analogy is unfortunately very accurate, and the clinical outcome of that is detailed in the complication reports.
Right, let's talk about those.
Specifically, the NICE guidelines reviewing the Gordon 2019 case series. We see exactly what happens when that wound healing cascade goes completely wrong.
Because the body still tries to heal. Right.
It tries, but without the hydration and estrogen needed for healthy neocollagenesis, which is the formation of new, healthy collagen, the body defaults to emergency repair.
Which means what, exactly?
It lays down dense, rigid, fibrotic scar tissue.
Let's really look at that Gordon data, because when you synthesize these cases, a genuinely horrifying pattern emerges from the sources.
It really is alarming.
You have these women who are seeking out these treatments just for mild pain or a feeling of laxity. They undergo 2 or 3 sessions of fractional laser therapy,
Yes.
and instead of rejuvenation, they return months later with severe lacerations. We are talking about deep tissue tears just from attempting penetrative sex after the procedure.
The structural damage is profound because fibrotic scar tissue does not stretch.
Right, it loses all its give.
Exactly. One of the most alarming outcomes documented in that series was a 65-year-old patient whose vaginal canal had foreshortened to a functional length of only 2.5 centimeters.
Wait, 2.5 centimeters?
Yes. The thermal damage and subsequent scarring had literally obliterated the functional depth of the organ.
That essentially makes penetrative sex a physical impossibility without, like, heavy surgical or therapeutic intervention.
It does. It completely closed it off.
And that wasn't just an isolated structural anomaly, was it? Another patient in that series developed I think the term was a crescent-shaped fibrous band right through the middle of the vaginal canal.
Yes, the laser induced a physical obstruction, a stricture. And the
Unbelievable.
complications aren't just structural, They are neurological and muscular as well.
Really? Like how?
The data highlights patients developing severe pelvic floor hypertonus and levotor antispasms post-treatment.
Which makes sense, right? If you inflict a deep thermal burn on tissue that can't heal, the surrounding pelvic floor muscles are obviously going to go into an intense guarding mechanism. They
Exactly.
just lock up to protect the injured area.
And that guarding response amplifies the pain exponentially. So think about it. A patient who originally had mild dyspareunia painful intercourse due to dryness
Right.
now has severe progressive dyspareunia driven by rigid scar tissue, foreshortening, and locked pelvic floor muscles.
The medical intervention took a manageably uncomfortable condition and transformed it into severe dysfunction,
Exactly.
which highlights the terrifying, tragic irony of this whole industry.
It really does.
You walk in wanting to feel more youthful, more comfortable, and to improve your intimate life. And because the underlying dryness was ignored, the device physically closes off the canal with scar tissue.
It's completely counter to the marketed goal.
And it makes the stance of ACOG, the American College of Obstetricians and Gynecologists, make total sense now.
Oh, absolutely.
They are adamant that vaginal rejuvenation is not a recognized medical term. It's just a marketing concept that masks the necessity of an actual clinical diagnosis.
And this raises a really important question about how we view medical technology as a whole.
How so?
Well, a CO2 laser is actually a highly effective tool in the right clinical context.
Right, the machine itself isn't inherently evil.
Exactly. But when an aesthetic clinic applies an energy-based device to a patient without first conducting a rigorous evaluation of their mucosal health, their pH, their estrogen status,
Yeah.
that is a failure of the practitioner, not the physics of the machine.
Right, so if the physics require hydration and cellular health to actually work safely, what is the proper order of operations?
That's the million-dollar question.
Because the guidelines from the British Menopause Society and the Women's Health Clinic are very aggressive about this idea of suitability first.
Yes, suitability is everything.
You don't start with the device, you start with the tissue deficit.
The consensus is absolute here. You must rehabilitate the tissue environment before you introduce any form of intentional trauma.
Diagnose, condition, then treat.
Exactly. And the gold standard for that rehabilitation is local vaginal estrogen.
And we should clarify this for the listener because there's a lot of hesitation around estrogen, rightfully so for some people.
Right, there is a lot of fear.
This isn't systemic hormone replacement therapy. You aren't putting a patch on your arm or taking a pill that circulates through your liver and your whole bloodstream.
No, not at all. The pharmacokinetic profile of local vaginal estrogen, whether it's a cream, a low-dose ring, or a small pessary, is entirely different.
Because it stays local.
Right. The systemic absorption is negligible. It acts almost entirely locally on those mucosal and submucosal receptors we discussed earlier.
Okay.
It literally reverses the biological cascade of GSM. It thickens the epithelium, restores the glycogen production, brings back the lactobacilli, and drops the pH back to normal.
It restores the water content. You are essentially putting the buffer back into the tissue.
Yes, you're giving the tissue what it needs to absorb the heat safely.
But I know a lot of patients, perhaps, those with a history of estrogen receptor-positive breast cancers, they're often advised against even local estrogen.
Right, that is a very real clinical scenario.
The guidelines do offer non-hormonal routes, but reading through it, the biophysics of those options are surprisingly complex. They draw a massive line between moisturizers and lubricants.
It is a critical distinction, and one that often gets overlooked when someone's just standing in the pharmacy aisle.
Yeah, what's the difference?
Well, lubricants are transient. They're used purely at the time of sexual activity to reduce friction, but they do not alter the underlying tissue architecture at all.
They just sit on the surface.
Exactly. Moisturizers, on the other hand, are designed to be used consistently, multiple times a week, to fundamentally improve hydration and lower the vaginal pH.
Okay.
They contain polymers that actually bind to the vaginal epithelium and hold water in the tissue.
But here's where it gets really interesting now. You have to read the labels on these things carefully.
You really do.
Because you can actually make the dehydration worse if you don't understand osmolality. The World Health Organization actually recommends that these products have an osmolality of less than 1,200 milliosmoles per kilogram.
Osmotic gradients dictate everything in cellular biology.
Right.
If a patient uses a hyperosmolar product, meaning The concentration of solutes in the gel is significantly higher than the concentration inside the mucosal cells. Physics dictates that water will move across the cell membrane to balance that gradient.
Wait, so the lube literally sucks the water out of your cells?
Yes, it strips the remaining intracellular water from an already dehydrated epithelium.
That is wild.
It leads to cellular toxicity and sloughin. So it might feel slip for 10 minutes, but hours later the tissue is more desiccated and more prone to micro-tearing than before you used it.
Wow.
So whether you're using local estrogen or highly specific isoosmol or moisturizers, the goal is always authentic cellular hydration.
Okay, so let's assume you've done the work.
All right.
You've spent months rehabbing the tissue. You've restored the pH, the thickness, the moisture. Is the laser ever actually indicated then? Can it actually be safe?
It can, provided the concept of tissue conditioning has been rigorously applied.
Conditioning, right.
The literature points to studies like the Marin 2019 report that focus on tissue preparation using systemic modulators. They look really closely at osbemifene.
Which is an oral selective estrogen receptor modulator, or a SERM.
Right.
SERMs are fascinating because they're essentially molecular keys that only turn certain locks in the body. Right.
Precisely. Osbemifene acts as an estrogen agonist specifically in the vaginal tissue, so it stimulates that cellular turnover and hydration we need.
But not everywhere else.
Right. It acts neutrally or even as an antagonist in breast tissue, which is why it can be safer for certain patients.
That's amazing.
And the Marin data demonstrates that conditioning the vaginal epithelium with something like osbemifene before introducing fractional laser therapy completely alters the outcome.
Because now the laser is hitting tissue that actually has intracellular water to absorb the heat.
Exactly. You've restored the buffer. The thermal energy stays constrained to the intended microcolumns.
So no deep burns.
No deep burns.
Yeah.
The healthy prime tissue can actually mount the proper wound healing cascade, deploying fibroblasts to lay down functional, elastic collagen, rather than that rigid fibrotic scar tissue.
So the conditioning not only makes the laser safe, but it also augments the actual benefits?
Yes, the efficacy of the neocollagensis is much better.
So if you are listening to this and you are experiencing pain, burning, or a feeling of laxity, you cannot bypass the biology.
You really can.
Walking into a Medi-Spa and demanding a laser because you saw a glossy ad is just a recipe for catastrophic structural damage. You have to diagnose the underlying genitourinary syndrome of menopause first.
Yes, the clinical reality is absolutely uncompromising on this.
Right.
Treating natural hormonal transitions as simple cosmetic defects that can just be burned away, it ignores the fundamental laws of cellular healing.
So to sum up our deep dive into these sources today for you listening, yes, cosmetic vaginal tightening procedures absolutely can make painful sex drastically worse.
Without a doubt.
If a fractional laser is applied to tissues suffering from severe, untreated dryness and estrogen deprivation, it bypasses healthy collagen stimulation completely and creates severe thermal burns.
Scorched earth.
Exactly. The result is rigid, fibrotic scarring, lacerations, and physical strictures that can obliterate the functional depth of the vaginal canal. You have to restore the cellular foundation before you ever introduce thermal trauma.
And, that biological reality leaves us with a pretty provocative consideration regarding the long-term mechanics of these energy-based devices.
Oh, what's that?
Well, let's say a patient properly conditions their tissue, undergoes the laser therapy safely, and achieves that healthy new collagen.
Okay, best case scenario.
Right. The fundamental driver of the original tissue degradation, the systemic lack of estrogen, hasn't been permanently cured, right? It's simply being managed.
Right, menopause is still happening.
Exactly. And since the laser relies on acute thermal injury to force a temporary spike in collagen production, does this mean the patient is now locked into a cycle? Will they require repeated thermal traumas every year or two as the new collagen inevitably degrades again in that low estrogen environment?
That's a huge question.
We really have to wonder if, by relying on injury to stimulate health, we are trapping patients in a permanent loop of maintenance rather than offering true long-term physiological resolution. Is the medical aesthetics industry prioritizing the sale of the device over the safety of the diagnosis?
It's a sobering thought, really, about the true cost of chasing rejuvenation through targeted injury. Well, thank you for joining us on this deep dive. Keep questioning the glossy brochures, protect your foundation, and always look closely at the science underneath.